Good evening to one and all. Welcome to yet another session of Transplant Forum. So now that we know the basics of liver organ anatomy and physiology, and now that we have also learned about the different causes of liver failure, the etiology and the management of liver failure, I think now it's important to know what are the indications of transplantation and what are the different workup tests that are required, not just for the recipient, but for the donors as well. So, as you know, liver transplantation is a very major surgery, and it's a process where the recipient and donor both have to undergo a major surgery. So, it is very important that we undergo a lot of tests to assess the fitness of both the recipients and donors. So, to elaborate on this topic, we have Dr. Dinesh Balakrishnan. He's working as professor in Amrita Hospital, Amrita Institute of Medical Sciences, Kochi. Just before we step onto the topic, I would like to give a short intro. So, sir is basically working in Amrita Hospital, and he has completed his MBBS from Calicut Medical College in the year of 1996. He completed MS General Surgery from Medical College Kottayam in 2001. And he did his DNB in GI surgery at Amrita Hospital and further pursued senior clinical fellowship in transplant surgery at Edinburgh's Hospital, Cambridge. So thank you so much, sir, for first of all willing to take this presentation. And I would like to hand over the session to you, sir. Thank you.
Thank you, Harita, for the kind introduction and this opportunity to speak. So I'm made to understand that this is the first of a series of introductory talks on liver transplantation. And today, though I have to speak about the indications, the recipient and donor workup and all that, I thought it would be in perspective to talk a little bit about the history of transplantation. So good evening to all our viewers. And so I'll start off by giving you a little bit of history. On the right side of the slide, you can find a very famous painting. This is sort of the painter saw a dream where he saw two saints, Cosmos and Damien, trying to put a severed leg together from another person. So this is one of the earlier depictions of a limb transplant being done. But ages before this painting was made, you would know that in Indian mythology, you would find that there is a lot of talks and tales about transplantation. The Lord Ganesha has an elephant head. And there is a mythological tale that the head was transplanted onto a boy after his head was severed by Shiva. But then in Indian mythology, many of these are symbolic of some attribute. So Lord Ganesha's big head is, your appetite for knowledge. The trunk is for flexibility. The big ears are good listening. So all these attributes in the symbol, it's symbolic of some attributes which every student should have. Similarly, the Ashwini Kumars, who are seen as physicians in mythological tales, had the head of a horse. But again, it's very symbolic. And we were ages away from doing a transplantation. So just to introduce you to the field of transplant, in the 17th century, the famous John Hunter had noticed an experiment of nature. So when he observed the twin cattle, the Freemartin cattle, he found that the male was normal, whereas the female was sterile. This was in the 17th century, and he just called it an experiment of nature. But he did not know why exactly this was so. Almost 100 years later, a physician wanted to know why exactly, and he started dissecting the placenta of these non-identical twin cattle. And he found that they had a shared circulation. And because of this shared circulation, the male hormone is now going into the female fetus very early in life, because of which the female fetus is sterile. So one part of the mystery was solved. But again, it took another 35 years for Ray Owen to do a few more experiments. And he found that these cattle had two different blood cells. So they were non-identical and they had two different blood cells, which again, biologically is not feasible. So he observed that because they had a shared circulation, and when the shared non-identical blood group is shared very early in life, probably the organism accepts it as its own. So this observation of Ray Owen made Peter Medawar, again, he was a zoologist, to do a mice experiment. So when embryonic mice, he injected embryonic mice with cells from different mice, and later did grafts, skin grafts from the mice from which the cells were taken, and he found that these grafts survived. So this was the beginning of transplant immunology and biology, and Peter Medewer is called the father of transplant biology. Way back in 1953, he published an article in Nature, which is called Actively Acquired Tolerance of Foreign Cells. So imagine, almost 75 years back, Peter Medewer was talking about tolerance. And today we know that the holy grail of liver transplantation is to achieve tolerance, which we haven't yet achieved. So from this historical perspective, let us look at a few people. I'll just show you a few pictures. So on the left side is Peter Medewer, the handsome man there. It's Peter Medewer, who first spoke about tolerance and demonstrated experimentally that tolerance is possible. On the right side, at the bottom, you have Joseph Murray. Now, Joseph Murray is the man who did the first transplant in the world. He did the first kidney transplant in the world. And he was a plastic surgeon. Even from his student days, he was intrigued that when an organ fails, why not put in an organ? So at that time, uh, there was a big dogma that arteries and veins can be put together, but lymphatics and nerves cannot be put together, and therefore transplant is impossible. So this is in the 1940s and 50s. So Joseph Murray wanted to sort of look at this. So he went to the animal lab, and what he did was he took out the kidneys of a dog and then put it back together, put the arteries and veins together. He left the nerves, he left the lymphatics. The kidney worked, made urine, and the dog survived. So he broke one dogma of transplantation, that nerves and lymphatics have to be joined for an organ to work. But still, he was far away from doing an organ transplant because cell biology, immunology was in its infancy, and nobody knew exactly, how a foreign organ can be put in another person with a successful outcome. So the first transplant was done by Joseph Murray in identical twins. So the Herrick twins, one healthy boy was okay, the other guy, his brother, had kidney failure. And the first transplant in the world was between identical twins. But then Murray didn't stop with that. He went on to experiment and study biology. He found how drugs, chemical immunosuppression can be achieved. So it's a long story, but as we go through today's talk, we'll touch upon all these topics. In the center, we have Thomas Tassel, who did the first liver transplant in the world. And then again, on the left side bottom, you have a bronze bust of Roy Kahn. So Roy Kahn was the person who used the first chemical immunosuppression, azathioprine. And FK506, or tacrolimus as we now know it, was first used by Starzl. So this is the paper that was published, which I spoke about, Peter Medewer in 1953, talking about actively acquired tolerance of foreign cells. Now, another picture here, this is Dr. George Hitchings and Gertrude Ilian. Both of them were pharmacists, biochemists, pharmacists, who were working in Burroughs Williams. And they dedicated their whole life to study the biochemistry of purines and pyrimidines. And it was this group of scientists who first discovered or chanced upon 6-mercaptopurine. So they were trying to look at whether 6-mercaptopurine is effective as an anti-cancer drug. And when they were using it, they found that these patients became immunosuppressed. So at about the same time, Joseph Murray was trying to find chemical immunosuppression. Roy Kahn was trying to look at some drug which can help keep the grafts that he was trying to put into patients. And they came across Dr. George Hitchings and Gertrude Ilian. And the first drug that was used to develop immunosuppression was a derivative of 6-mercaptopurine, azathioprine, which we still, to this age and day, use. So why azathioprine? Because they realized that the therapeutic index of azathioprine was the safest. But again, the dose, the amount required, all this was not very clear. The discovery of azathioprine is probably the dawn of modern immunosuppression. Now, with that background, I would add a little bit of history and then go on to our talk. So this is an article which was published in 1968, a definition of irreversible coma. So this was the first time somebody had tried to define brain death. And this particular definition holds to this day. Why I have put it here is because as biochemists, physicians, pharmacists, basic scientists, and surgeons became aware that transplantation is going to expand by leaps and bounds and is going to be a very effective treatment for end-stage liver disease or kidney disease, they were also trying to look at how they can procure organs. And that was the situation that they were. And then brain dead patients, they realized, would never come back to life. And these are probably patients who can donate their organs to save people who have end-stage disease. So the definition of brain death happened way back in 1968. And from the 70s, the Western world has accepted this concept. But it is sad to say that, even today in our country, brain death has not been accepted. And many people, we are yet to sensitize our public that brain death is death and organs can be donated. So now let's look at the success story of transplant. In the background of all this history, in those early days, in the 1970s, 60s, and 70s, when surgeons and transplant physicians were trying to put in an organ, the success rate of transplant was abysmally low. But today, if I look at this UNOS data of 2010, you know that the 3-month survival is 95% across diseases, whatever be the indication. In chronic liver disease, whether it is alcoholic liver disease, viral diseases, or it is for an HCC, the 3-month survival is close to 95%. The 1-year survival in most transplant centers of the world is close to 90%. And you have excellent long-term survival, 10 years, 70%. So transplant as a very effective option for end-stage kidney liver disease has been established. And it's a potential solution for all these problems. Now, what are the indications for liver transplant? To put it very simply, there are two basic indications. One is a patient who develops acute liver failure. No pre-existing illness, but then due to an acute insult, which can be a virus like hepatitis A, or it can be a poison, or it can be a flare-up of an autoimmune condition. It leads to an acute insult to the liver, resulting in two basic things. One is encephalopathy and coagulation failure. And then there are various criteria whereby you select a patient for transplant as a life-saving option. So one is acute liver failure. The second indication is end-stage liver disease, or what we commonly know as cirrhosis of the liver. When cirrhotic patients develop a decompensation, which can be in the form of having a massive bleeding, or a refractory ascites, or a hepatorenal syndrome, a development of an HCC, they need transplant as a life-saving option. The third indication is malignancy, especially primary liver tumors like hepatocellular carcinoma. You can also have metabolic disorders, especially in the pediatric population, various metabolic problems like amino acid ureas, thyrosinemias, glycogen storage, urea cycle defects. And one of the most common indication in the pediatric population is biliary atresia, whereby, embryologically, a newborn baby is born with atretic biliary system leading to cholestatic jaundice. Now, if you look at the wait list in the Western world, you find that there are more patients who are in need of organs than there are organs. Many patients are on the wait list, waiting for an organ to come out of their serious illnesses. And the Western world depends largely on brain dead organs or a non-heart beating organ to do a transplant. Unlike that, in Asian countries like India, Japan, Korea, and China, brain dead donations are few and far in between. And in our country, it is always a live donor, a family member who comes forward to donate either half a liver or a kidney to save the life of a near and dear one. So again, this is a slide sharing primary liver disease in the pediatric group. I would not elaborate on this because, as I said, the most common indication is biliary atresia, followed by acute liver failure in the pediatric population, which can be either viral or metabolic. and then various rare diseases for which transplant is a solution. Is there an absolute contraindication to do a liver transplant? Well, if a patient is unable to understand, comply with immunosuppression, is not a sound mind, probably one should think twice before putting in a transplanted organ, because you need to be on immunosuppression lifelong. If they have active sepsis, like the blood culture is positive, you have organisms in the blood, then yes, it is a contraindication, because as you do a major surgery and try to immunosuppress them, they'll succumb to multi-organ failure. A primary liver cancer, which is advanced with vascular invasion or a metastatic disease, is an absolute contraindication. Advanced cardiopulmonary disease, HIV, where treatment has failed and patient has got various opportunistic infections, documented anatomic anomalies precluding transplant, like the portal vein and the superior mesenteric vein is completely thrombosed. You can't do an isolated liver transplant. And any extrahepatic cancer, especially a recent history of extrahepatic cancer, is a contraindication. Coming to relative contraindications, elderly patients who have comorbid illnesses, active alcoholism, because you need patients to abstain from alcohol. After a transplant, there is a chance that patient can go back to active drinking and then the graft will fail within a year. Malignancies like cholangiocarcinoma, one has to select very early disease, and very carefully selected cases only can undergo transplant. So it's a relative contraindication. Severe sarcopenia, is it a contraindication? It is not a contraindication, but then these patients may have poor outcome because of poor physiological reserve. Now, when to transplant? How early is early? How late is late? So when a patient has chronic liver disease, doing a transplant very early is, one should think twice, because many of these patients, if you can, like somebody is taking alcohol, he abstains, there's a chance that he may stabilize and he can be on follow-up. Similarly, hepatitis C virus, as you all know, is eminently treatable. You have a very effective drug like sofosbuvir. So direct acting antivirals and the discovery of these drugs have led to many of the previous transplant indications now stabilizing and being on follow-up. So if a patient has a low MEL score, a MEL's less than 10, then probably one should think twice, sorry, before you decide on a transplant. And how late is late? In our country especially, many people keep transplant as a last option. One has to realize that transplant is not the last option, but probably it is a good option in carefully selected patients. So if you wait too long, they become sick, they become septic, they are in the ICU, they may need organ support, and in these cases, the outcome is bad. So one should probably start evaluating a patient when the MEL score is more than 10 and look at treatable causes for his disease. Now, sodium, for every milliequivalent drop in sodium, there is a linear increase in mortality by 5%. So in the MEL score, they have added sodium to the MEL score. It elevates transplant priority for about 12% of listed patients. So in a recent study, I think it was published in 2020, they realized that even patients with a MEL score between 11 and 13 stand benefit from a transplant. So if you look at these graphs, you'll realize that at a score of 6 to 10, patients can wait for up to 300 days. At about a year, their chances of health deteriorating, as you can see here, this black graph is coming down. At 11 to 13, at about 100 days, the graphs are crossing. The patients who get a transplant at about this time tend to do well, the others can deteriorate. But between a score of 14 to 16, about 50 days, there is a deterioration. So essentially, it goes to say that any patient with chronic liver disease, if they have a MEL score between above 15, they should be assessed for a transplant, because they can have decompensations which make them very sick, which make them end up in the ICU with life-threatening complications. So they should be under the care of a hepatologist who would closely monitor them. Now, how closely should they be monitored? if you have a MEL score of more than 25, probably you should see your physician every week. And they have to be, they have to be planned and taken up for a transplant as early as possible. Between a MEL score of 19 to 24, if you do not have a donor and you are on the transplant waiting list, probably you should see a physician every month. Between 11 and 18, every 3 months. And if your score is about 10 or so, the chance that you may become sick is less than 10%. So you can see a physician probably every year. Now, though we all score, there are MELD exceptions. You may have a low MELD score, but you may have an HCC, which is not amenable to treatment options like ablation or surgery because the liver is cirrhotic. These patients stand to benefit from a transplant. Refractory ascites, MELD score may be low, but the patient will have ascites. You cannot treat them with diuretics. They may be either, they start developing complications when they are on diuretics like hyponatremia, or even with good doses of diuretic, they need frequent tapping. These are patients who would benefit from a transplant. Patients who have hepatopulmonary syndrome and hypoxia and orthodeoxia. Orthodeoxia is basically in cardiac failure, you get dyspnea in the lying down position, whereas in orthopnea, you have, when you get up, you have difficulty. Now, primary biliary cholangiopathy, the indication is severe pruritus affecting quality of life. So they may have MEL score, which is low. Familial amyloidotic polyneuropathy, again, low MEL score, but they have significant quality of life issues. And primary oxaluria, where the kidneys are laden with stones, that they go into renal failure. And if you are planning to do an isolated kidney transplant, the transplanted kidney will within a short time develop oxalate stones. So this is an indication where you have to do a liver kidney transplant. The liver uh, may not be affected, but there's an enzyme deficiency leading to multiple stones in the kidney, leading to renal failure. So primary hyperoxaluria is a MELD exception where you have to do a liver kidney transplant. So you do not always go by MELD score. There are MELD exceptions, and these are a few of the common MELD exceptions where you think of doing a transplant even with a low MELD score. Now, coming to acute liver failure, we had mentioned that it is one of the indications for a liver transplant. Now, how do you define acute liver failure? It is the simultaneous appearance of hepatic encephalopathy and coagulation defects in the setting of an acute liver insult of any kind in the absence of pre-existing liver disease. It is further defined as hyperacute when the onset is within less than 7 days, acute within 1 to 4 weeks, and subacute if it's more than 4 weeks. Now, hyperacute is when it occurs, when the encephalopathy occurs as soon as the onset of disease, has a better chance of recovery than acute or subacute. So when do you have to do a liver transplant in acute liver failure? How would you select a patient for transplant? Now, there is no ideal selection model for patients with acute liver failure for transplant, but there are various models which we depend upon. One of the most popular model is what is known as the King's College. So King's College has a criteria for paracetamol and a criteria for non-paracetamol indications. Sorry. So for paracetamol, a pH less than 7.25, more than 24 hours of fluid resuscitation is in itself an indication for an emergency liver transplant. Paracetamol indications, which may be viral, autoimmune. If the prothrombin time is more than 100 seconds or INR more than 6.5 in the presence of encephalopathy, it is an indication. In addition to this, if you have a creatinine more than 300 micromole per liter, which is roughly about 1.7 milligram per deciliter, and patient has grade 3 to 4 encephalopathy, if two of these criteria are there, again, they are indications for an emergency liver transplant. Well, when will you not think of transplant? When there is raised ICP, the inotropes are rapidly increasing. We'll come to it in one of the slides in the next few slides. So inaccurate selection. So in a acute liver failure setting, one thing that we should all be mindful is that we should not be in a hurry to transplant. They should meet criteria. If you do it without meeting criteria, you may be doing an unnecessary surgery where the patient has to be on lifelong immunosuppression. Again, utilization of a scarce resource, especially if the patient is on the brain dead organ donor list, etc. And even the complication of doing a major transplant, because as you all know, transplant is not a 100% successful operation or procedure. It carries its own morbidity and even a possibility of mortality. There's no proven model which will accurately predict who will benefit from liver transplant, but depending on the situation, you can choose either King's College criteria or in places like, for example, in our state, in Kerala or in India, where rat poison is a cause for acute liver failure, we have developed our own criteria. For example, in Amrita, we had looked at the rat poison patients and we uh, do not transplant them, even if the INR is more than 100, prothrombin is more than 100, INR more than 6.5, if they are not encephalopathy. Onset of encephalopathy makes it mandatory to do a transplant because those patients who unfortunately could not be transplanted due to lack of an organ, all the patients who developed encephalopathy after rat poisoning could not make it. And there was almost 100% mortality. So depending on the clinical situation, we may have to choose a criteria. Again, patients who have a very high MEL score, acute liver failure patients with a very high MEL score, have a high risk of mortality. So an admission MEL more than 35, almost 64% of patients died in comparison to about 24% when the MEL was less than 35. So in acute liver failure, if they meet criteria, yes, transplant is life-saving. You should assess these patients thoroughly. You should see that their brain function is okay, the pupils are reacting, the intracranial pressure is not very high. We would do an MRI to see if there is any uncal herniation. We should look at comorbidities. They should not have comorbidities which are not compatible with survival. So if they do not have any of these major issues, then we should proceed. Who are the patients who should wait? Patients showing sustained evidence of improvement. For example, patients who are coagulopathic, INR is 6, and then next day without correcting, without giving plasma, INR comes down to 4 or 5. One should give time and wait. Paracetamol-induced acute liver failure who do not have grade 3 or 4 encephalopathy, one should wait. Patients with paracetamol-induced acute liver failure and severe acidosis or elevated serum lactate that responds to resuscitative measures, one should wait. And again, most patients, when the liver allocated is marginal, like, you have no live donor, you are on the list waiting for an organ, and the organ that is offered is very marginal, very fatty liver, ABO incompatible, elderly donors, possibilities where the patient can develop primary non-function because these are extremely sick patients and they need a graft to work immediately if they have to come out of their clinical predicament. When should you not do transplant in an acute liver failure? When there is evidence of compromised brain stem function, autonomic instability, pupil not reacting, an MRI showing flow voids, absence of flow voids, uncal herniation, one should counsel the family and refrain from doing a liver transplant because the outcome can be poor. If they have an invasive fungal infection, we cannot do a transplant. They will worsen, the infection will progress, and there's a very high chance for mortality. Rapidly escalating inotrope requirement. Somebody who required a minimal dose of inotrope goes on to develop 1, 2, 3 inotropes, escalating dose of inotropes, one should not do. We have also realized that patients who develop kidney failure have a bad outcome, though it is not an absolute contraindication. In our own series, when we have looked at patients who had elevated creatinine and need for dialysis pre-transplant, the outcome has been bad. In addition to this, hepatitis A virus patients can have severe pancreatitis. And severe pancreatitis, though not a contraindication, again, has poor prognosis after emergency transplant in acute liver failure. So various criteria and their sensitivity and specificity. As I mentioned before, no criteria is ideal. I think I'll skip this slide. We have already discussed regarding this. This is regarding liver transplant in hepatocellular carcinoma. So again, HCC, if they meet criteria, so what is the conventional criteria or the well-established criteria? This is what is known as the Milan criteria. So a single HCC tumor less than 5 centimeter or 3 nodules, each less than 3 centimeter, classically is within criteria. And if you transplant in these patients, the outcome generally is very good. Again, there is no ideal criteria. As you choose criteria with good outcome, you become too restrictive. So there are many new criteria have come up. So you have the Milan criteria, which I just mentioned, where the 4-year survival is 85% and recurrence-free survival of 92%. You have the UCSF criteria, again 6.5, single tumor of 6.5. So you are expanding the criteria. Again, with good survival, 1-year survival of 90%, 5-year survival of 75%. But this is the up to 7 criteria, up to 7 sizes, maximum size of 7 centimeters, up to 7 tumors. So as the criteria expands, you have to pay a price. What is the price? The price is the chance of developing recurrence. Again, the metro ticket concept. The further you go, the bigger price you have to pay. If the AFP is more than 1,000, if the tumor has microvascular invasion, if it is a large tumor, definitely the chance of recurrence is high. So one has to choose your patients for transplant, especially with HCC, because the price that you have to pay when you choose patients who have large tumors, who have high tumor marker levels, is the possibility of recurrence. So that is the 5-year overall survival and the recurrence-free survival. When you choose the various criteria that is applied for choosing patients for hepatocellular carcinoma, so the various criteria, Milan, UCS, up to 7, ASAN, there are multiple criteria. Each country has its own choice. So depending on, but if you are in the Western world, where it's a brain dead organ, most people would follow Milan criteria or UCSF, and they are very reluctant to expand the criteria. Now, I think we'll come to pre-transplant recipient evaluation. So whenever you are considering liver transplant, it's a very major undertaking, and you have to sit with the family, discuss with them, make them aware about why they need the transplant, what are the alternative treatment options available, why one should choose one over the other, and only after a detailed discussion with the family and trying to understand what the family or the patient actually wants, should one venture into doing a liver transplant. Is there an alternative treatment for the liver disease? These are questions which the patient's family often asks us, and we have to share with them whatever information is available and why we are not choosing one over the other. Can the patient survive the operation and the post-operative period? So to part of the pre-transplant evaluation. So we have to assess their comorbid illnesses. Do they have severe cardiopulmonary disease? Will they withstand a major surgical procedure? So cardiac evaluation is one of the major pre-transplant evaluations that we do. Senior cardiologists would do an echocardiogram, do a stress test to see if they can go through a very major surgical procedure. If on the stress test they find that the patient has got compromised coronaries, we may have to do an angiogram and look at the coronary. Is it possible to better the transplant survival possibility by optimizing the coronary blocks? So these are all discussions which happen in the pre-transplant evaluation phase. Do they have other comorbid illnesses that severely limit patient survival, making transplant inappropriate? Somebody who has got progressive interstitial lung disease, who where it is not reversible and they have significant issues, then they keep coming back to the ICU. One should think twice about doing something like a liver transplant. Can they comply with complex medical treatment? Because post-transplant, these patients have to be on immunosuppression lifelong. So, for example, a patient who is ethanolic, who has not abstained from alcohol, one has to do a clinical psychology evaluation to see what the risks are that he'll go back to drinking. What are the risks of him not complying with medications? And is the recurrence rate of the disease in the transplanted liver acceptable? For example, if you're transplanting for a advanced hepatocellular carcinoma or for an indication which is not a usual indication, many a time the family wants to save life at any cost, but the disease is not a usual indication for transplant. They're saying, no, we want to transplant. For example, metastatic disease in the liver. These are cases where we have to tell the family that despite whatever you do, there's a possibility of recurrence, and transplant is probably not the treatment option in that particular scenario. So this is a flow chart for recipient evaluation. So as I mentioned, it involves a thorough history taking, physical examination, doing blood test, which is based on a protocol developed by the institution, doing an echocardiogram, dobutamine stress echo, if required, a coronary angiogram. And then after all the organ system assessment, have a pre-transplant meeting where we look at the comorbid illnesses, the anatomical challenges that we can face during transplant. For example, if somebody has got a portal vein thrombosis, which is extending into the superior mesenteric vein, what are the options? Can we get around it and give good inflow to the transplanted liver? So it requires a lot of pre-transplant evaluation and assessment. So a quick look at the routine workup. I'm not going to go through this. It's a long list, but one would do blood biochemistry, which involves a blood count, liver test, kidney profile, coagulation profile. If it is a young patient, we would do a autoimmune workup of the patient. Always one has to look at the hepatitis B, C status of the patient. For example, if they have a core antibody, hepatitis B core antibody positive, it means that they've had a past infection. And post-transplant, these patients can have a flare of the disease because the B virus never goes away. It will be there in your reticuloendothelial system. So these patients have to be on lifelong antiviral drugs like tenofovir. So a complete workup and assessment to know what the virus status of the patient is very mandatory. One has to screen for neoplasms. For example, when you do a tumor marker and you find the CEA is elevated, they may have to undergo a colonoscopy. Some of these patients may have a underlying colorectal polyp or a malignancy. So one has to screen for neoplasms. One has to look at the lungs. The OGD will look at the stomach. So all this is part of the screening. If it is a lady, a gynecology assessment, a pap smear, and a mammogram, especially in patients who have a family history of breast cancer, past history of malignancy. So all this has to be looked up before doing a transplant. So chest X-ray is mandatory, pulmonary function test, blood gas analysis, 2D echo, stress like dobutamine stress echo, even a coronary angiogram. Now, nutritional assessment pre-transplant, what is known as prehabilitation, is a very vital component before you do a liver transplant. Many of the transplant patients are sarcopenic, they have poor muscle reserve. So post-transplant, these patients are at risk for now increased days on the ventilator, increased ICU stay, chance of infections and pneumonias are higher in patients who are sarcopenic. So one way of looking at sarcopenia is to do the CT psoas muscle index, which gives you a very objective idea about sarcopenia. So these patients can be prehabilitated. Their nutritional requirements can be met pre-transplant. They can be given a high protein diet. Now, many of these patients may have a high BMI, but that doesn't mean that they are not sarcopenic. They have what is known as sarcopenic obesity. They have fluid overload, but their muscles are very wasted. Now, psychological assessment is also very important. One has to be compliant with medications. They should have good family support. Financial assessment is a very important part of transplant because it involves spending a lot of money, not just for the surgery, but post-surgery also, medications, follow-up visits, need for imaging, especially CT scans, and if sometimes even when they have biliary problems, an MRI. So all this has to be looked at in detail. Smoking cessation, alcohol abstinence, and compliance with abstinence post-transplant. Now, extended criteria donors are always in the uh, purview of brain dead organ donations. But in our country, most of the donations are live donors, family members. So the donor doesn't need a surgery. They are coming forward to save the life of a loved one. So it is the duty of the physician and the transplant team to see that the donor comes to no harm. So they will be assessed and they'll have to go through a lot of tests and see that they're super fit before they go on to become an organ donor. So a donor evaluation requires them to have normal biochemical tests. They should not have a fatty liver. Their anatomy should be acceptable. Ideally, their body mass index should be ideal. Anybody with a BMI more than 35 stands the risk of pulmonary thromboembolism, and they have increased morbidity as a donor. So one should very carefully select a donor, especially a liver donor. So every center has a protocol based on which they would select their donors. Now, coming to a donation, as I mentioned, there are two types of donors in the Western world. Brain dead organ donation is the norm. So, when one is brain dead, there is no spontaneous respiration. They are on a ventilator. When you test the cranial nerve function is lost. So, there are criteria for certifying brain death, and 6 hours after certification, a second team would assess brain death. And if they are declared brain dead, then they'll never come back to life. So, in the Western world, most of the organs come from brain dead patients. Now, in the Western world, donation after cardiac death also occurs. So these are patients who are extremely unwell, who are not going to come back with life. And there is a lot of detailed discussion with the family as regards withdrawal of care. And when that patient develops a cardiac arrest because they have consented previously itself, the patient goes for a quick, super fast retrieval of organs. So unlike the Western world, in our country, brain dead donation is very few. So we largely depend on live donation. So when it comes to brain dead donation, there is a period of obligate period of warm ischemia, especially in DCD donors. And there is also a period of cold ischemia. For example, livers have to be transplanted within 12 hours. So up to 12 hours, cold storage is acceptable. Now, contraindications for diseased organ donation, infections like HIV, systemic viral infections, active malignant disease, active sepsis, which can be bacterial or fungal. And when patients are considered as kidney donors, somebody who have failed, like kidney failure, even AKI may not be chosen to be a kidney donor. Graft types, cadaver grafts obviously are whole grafts. They can be split and the left lateral segment can be taken for a child. So in a brain dead donation, to increase utility, you can take the right lobe for an adult and the left lateral for a child. In live donation, between adults, it's always the right lobe, which is segment 5, 6, 7, and 8. For a child, you can take the left lateral segment, which again has to be reduced in a very small child, less than 10 kg. You have to reduce even this graft. The anatomical type in a liver transplant, it's always orthotopic. The liver is put in the position of the normal position of the liver. So these are some of the incisions which are used for a liver implant. But what we do is a reverse L incision. Always the diseased liver is removed by surgery. The diseased liver carries a very high risk for malignancy. The cirrhotic liver harbors a chance for HCC, so the diseased liver is removed, and in this orthotopic position, the graft is put in. So as you can see here, when a graft is put in, first the outflow is reconstructed. The right hepatic vein and the middle hepatic vein in half a liver or a right lobe is joined. The portal vein is joined to the portal vein of the recipient. The artery is joined to the artery of the recipient, and the biliary anastomosis is re-established. So this is the inflow, and the outflow is the right hepatic and the middle hepatic in a live donation. So I think with this preliminary discussion, we have touched upon the historical basis of transplant. It is only 70 years since the first transplant was done in the world. Even in 1953, Peter Medawer spoke of tolerance. And we are yet to achieve the holy grail of tolerance where after transplant, immunosuppression is not required. In our country, brain dead donation is few and far in between. So I think as responsible citizens, it is our responsibility to sensitize the public, to let them know that once you are no more, you can probably donate your organs because you are donating or giving the gift of life. There's so many people who are on the wait list for an organ. Lakhs of people are depending on a machine for dialysis. If they get a kidney, they can beat the machine, they can lead productive lives. They need not come to hospital 3 to 4 days of a week and get dialysis. So probably the public doesn't know that so many people are in need of organs. And it's our responsibility to sensitize the public and let them know that so many people are waiting and so many people are unwell. In the rare instance that one loses one's life and is brain dead, probably one can give the gift of life. Before I conclude, this is the team in which I am working, but this is not the entire team. This is only 20% of the team. Most of the people in this photograph are surgeons, but it would take close to 100 people to do a liver transplant and look after a patient following transplant. You need the help of the nursing staff. You need the help of social workers, pharmacists. A lot of people are involved in sending a patient home and looking after them post-liver transplant. I'm happy to say that I am also part of such a large team, about 100 people, 100-strong team, looking after people who have end-stage liver and kidney disease for whom an organ can give them quality life. Thank you so much for the patient listening. Thank you very much for this opportunity.
Thank you so much, sir. I think you have given a very detailed presentation on you have covered all the topics about the organ anatomy, the workup, and the donor selection, the recipient selection, and all the things. So, thank you so much, sir, for such a wonderful presentation. So, just a couple of questions before we wind up the session. So you had mentioned, we know there are two types of donors. We have deceased donor liver transplant and live donor liver transplant. So when it comes to deceased donor, what are the major criteria that you look into, like before retrieving an organ from a cadaver? So what are there anything like something major things that major criteria that a organ, they should be fulfilled or anything like that? So how do you know whether we can proceed with that organ or not?
So basically in disease donation, these are very sick patients who have come into the ICU with a major problem. So as you know, most of the brain dead organ donors are victims of road traffic accident. They have had a catastrophic injury to the brain. The brain is shattered. They are beyond, salvage. And then the neurology critical care team is looking at a patient who's brain dead. The pupils are dilated. Just the cardiac pacemaker is making the heart beat. They're maintaining their blood pressure, but these are very, very sick patients in the ICU. Now, when somebody is brain dead, it is futile to keep them on a ventilator and give unnecessary treatment. So it is a duty of the critical care team to break this bad news to the family. And they're going to tell them that, see, we can't do anything. Whatever we have done, we are not able to save life. He is brain dead. So the first part is breaking the bad news. Now, it is not right, and no ICU in the world would do a lot of tests on these patients to see whether their organs are okay. But then, after breaking bad news, for some families at least, when they are given this option that, this person is brain dead, there is a possibility that organs can be given to somebody in need. Some families, this gift of giving life is very cathartic. Though they are very emotionally disturbed, they want to go through this process. So once they give consent, we can do some tests, but without charging the patient or the family, we can do some tests. Only basic tests are done. For example, if you are retrieving a liver, we would want to know the liver tests. If the liver SGOT, SGPT is not very elevated, if the enzymes are not very high, we would accept it. Less than 100, we would accept it. Basic bedside ultrasound imaging shows that the liver is not cirrhotic. That's okay. That's all right. Now, if the viral markers, HIV screening is negative, we'll accept it. If their sodium is not very high, because brain dead patients can have hypernatremia. If they have a sodium of 170 or 180, possibilities are very high for primary non-function. So these are all simple tests, but based on this, a retrieval surgeon will decide whether this organ can be accepted or not. Now, when you go out to retrieve and open the abdomen for retrieval, there may be things which will make you decide not to take this organ. So a retrieval, it is the retrieval surgeon's responsibility to see whether they have any malignancies. You open and find some nodule somewhere, a mass in the colon, well, you should not take this liver. But pre-operatively, trying to do various tests to find out if they have all these things is not right, because they are very vulnerable patients in the ICU. So it is the retrieval surgeon who takes a call. This liver looks good. This liver is okay. The tests are acceptable. The sodium is okay. Chances are this liver will work in another patient. If the liver looks very fatty, you can on table take a biopsy, ask a pathologist to have a look. If it is not severely fatty, if there's no fibrosis, you may accept an organ. So basically, absolute contraindications are, like I said, active sepsis, bloodborne sepsis, HIV, any active viral illnesses you would not take. If the liver is reasonably okay, if the biochemical tests are reasonably okay, it's a retrieval surgeon's call to accept this organ. And based on experience, they take a call and communicate with the team. I think this organ looks okay. It can be used.
Thank you, sir. And the next question, so when it comes to living donor, so what can a donor expect out of, after the transplantation? Because I think there's a common question from the donor side, like how long it takes for the liver to completely grow back, or whether it grows back or not. So there are a lot of queries from the donor side as well, whether they require any medications, and what will be there, any precautions they have to take after donation of the liver. So what do you have to say about that, sir?
So again, mostly it is most of the donors are close family members, and this decision is a very emotional decision. You know, a brother or sister, husband or wife donating for their loved one is a very emotional decision. So it is a responsibility of the transplant team to see that they are absolutely okay to go through the surgery. So it involves a very protocol assessment, and we share all the details with the donor and tell them it's a very major surgery. This is what you should expect. You should The day after surgery, you will be in an ICU with a lot of lines and tubes and such on you. So we sort of prepare them for this procedure. We tell them that they need to spend 2 days in the ICU, about a week in ward. A very rare 10% possibility of having a complication like having a bleed which requires transfusion, or a 5% chance of having a bile leak. So all information is shared with the donor. So after this, like next day when we see them in the ICU, we often ask them, is it like what you felt? Is it like what you expected? And some of them would say, no, I didn't feel anything. Well, I have some pain, and then you have to address all that. Now, post-surgery, after about a week or 2 weeks, they are up and about. They are able to do their normal activities of life. Yes, you are right. All of them ask how long will it take for them to come back to normal life? So we would tell them about 2 to 3 months. So young people donating, they can do normal things. They can do their daily activities of life. If it's a desk job, they can work. But if it's a job which requires a lot of physical effort, we would tell them 3 months or 4 months only after should they get into such things. If they're young people who want to do contact sports, 6 months. They want to do a vigorous dance or some very ballistic exercise, maybe 6 months. But most of them would recover in 2 months. They're up and about, they look okay. Like as you know, in our program, it's a robotic program where the donor has a fan incision. So the incisions are becoming smaller, the muscle cuts are coming down. So probably we have not objectively assessed, but probably all this adds to patient recovery. Your second question is, do they have to take medications? No. They do not have to take any medications lifelong. The liver grows back in 6 weeks, and they, on long term, they are normal people. They can do all activities of life and go about their life like normal people. The liver regenerates. But it's a very major surgery, and we have to share and make them aware about that big decision that they are taking to go and donate.
Thank you so much, sir. So I think you have wonderfully answered all the queries and you have done a very great presentation. So thank you so much, sir, for your time. I'm sure all the students might have very well understood each and even the basics of transplantation right from the beginning. So thank you so much for your valuable time, sir.
Thank you, Haridha, for the opportunity.
Thank you,
Thank,
sir.
thanks.